Маєте права? Підключайте, підключайте. Наступного спікера Олександр Владимиров.
Йому треба, скажіть, будь ласка, йому в зумі, щоб він виходив і він... Ні, просто мікрофон скажіть, він вас чує. Просто скажіть, Олександр Бутов, мені треба просто, щоб він слово сказав.
Ага, все, прийнято. Ви виведете, так? Все. Гаразд. Продовжуємо. Наша наступна...
So let's continue our next clinical session. We will speak about the spinal cord injury and rehabilitation medicine in this and urological and neurourological aspects included. So I would like to give the floor to Alexander Vladimirov, our head of the Society of Medical Medicine professor and head of chair of sport medicine of our University of Protection of Medicine and so do you see our presentation? My presentation? Yes, I see this presentation. We see it. So, dear friends, I am very happy to greet you with this event, which is going on in Klevan. Our colleagues, they are having a very powerful international conference, and it's very pleasant. So I see this activity with more than 300 people online and a lot of people in the room. And secondly, I would like to congratulate you on the embroidered shirts day of Ukraine, and I would like to wish you all successes. Today I would like to share with you all the plans for preparation and training of physical medicine specialists in our specialty. So I would like to give you a very good news. You see the new edition, new publication of Ukrainian physical rehabilitation medicine journal. So it's number 2 in 2024, and the whole publication is devoted to the works of our very well-known scientist and our colleague from Canada, Andrei Krasikov. So you see my speech to the specialist, and we see the translation and the original version of 2019, and also different translations of different versions, which were in English and now translated into Ukrainian. So we see that we need fully these two standards for specialists of rehabilitation, neurologists and urologists, and our professors in universities for training of physical and rehabilitation medicine doctors. And I would like to thank a bigger friend of Ukrainian people, well-known scientist and humanist Andrei Krasikov, who did this gift to the Ukrainian medical community, and big thanks to Andrei to selecting our journal for publication of these articles about the standards of ATA. So you see in this journal, it's very short. We tell about this person, and this material is prepared for the final annual version. But in short, Andrei Krasikov is the first Canadian doctor is the first president of American Association of Spinal Cord Injury, and thanks to Andrei for doing this for our field of rehabilitation. As for the training, so we continue this.
4 кредити.
We continue with specialization of 720 hours with 72 credits, and this is a very big number of students that are trained, and we have more than 2,000 doctors being prepared. So this is quite a big number, but it's a very big problem as well, because the doctors of physical rehabilitation medicine, they don't get appropriate high qualification, and they do not arrive to the medical facilities where the rehabilitation assistance is provided. So that's why we have the problems and issues about this speciality and this specialization, and there is a proposal to stop this training since 2025, to stop preparing such doctors and be focused on intern training. So we have enough interns. So you see, we started since 2020, and last year we had the first graduation of specialist. This year it will be the second graduation of students who study for 3 years, and unfortunately this year there will be the first intern graduation of interns who studied only for 2 years. So according to the orders of the Minister of Health, so they put put students into 2-year internship, and these doctors, unfortunately, they will not get the appropriate knowledge on physical and rehabilitation medicine. But the positive thing is we achieved that the doctors will pass the exam Krok 3 as other doctors, and for the first time this exam on the 31st May, they will have this exam, and they are being prepared. And we spoke with several people from different universities. And as about the internship, so the Minister of Health, and we submitted it to Honorable Victor. So we submitted a letter in February this year about turning back the 3-year specialization, but we expect for the reply. So you know that in the multidisciplinary teams we can introduce or maybe include the rehabilitation and also social work in such teams, and we will see on with example of Klevan hospital how the social worker will work. So now in our country we will introduce the orthosis and the processes production, and of course the numbers are very modest. I will not tell it at all, but today the Ministry of Health allowed to the third in medical educational institutions in Kharkiv, in Lviv, and Institute of named after Shupak in Kiev, uh, gave the orders to start training the specialists on orthosis and processes. Then the new code of specialties and the Ministry of Health also insists on speed up of licensing of such institutions for these specialties. Of course, we don't have enough these specialists, and we have problems to find new professors where to train, in which centers, and where we can produce the instruments, the ortheses and the prostheses, and considering the vague situation about the staff, the National Institute of Health, we gained the grant on finding the needs in the educational institutions about the introduction of new model and of number of students. So we need to define for the ministry how many specialists in the multidisciplinary teams should be trained inside Ukraine to assure our new system of accreditation, which is being introduced. So now I will show you the new prices, and today Volodymyr was saying how many institutions were the contracted institutions according to the packages, but I would like to draw your attention to that the money is paid, but the services should be provided in a with a high quality. But here we have a number of problems related to absence of competence of our specialists and doctors on rehabilitation medicines in providing services in the packages, and also ambiguity and the absence of the policy of the national health service in the sense of criteria, and so there are lots of things which should be solved now, and the huge number of specialists asked the service with proposal how to improve the rehabilitation services and in which fields, and we discussed this in the department. Many proposals are very relevant, but they need to be worked out so that we would be capable to make a letter, and our society already prepared a draft letter, but we needed to add the proposals as an appendix, and as soon as we do it, the document will be submitted to the Ministry of Health and the National Health Service of Ukraine. And pleasant news, international community society ISPRM confirmed the certificate that we, the Ukrainian society, we as a partner of international society, we paid with success. It was quite difficult to pay this entrance fee, and now 220 members, permanent members of our society, physical and rehabilitation medicine doctors, they can get the code for access to documents of IRSPM, and they can print them for themselves. The day before yesterday, the public organization, Ukrainian Society of Rehabilitation Medicine, there was the agenda, and you see this agenda here, and we will raise very substantial points at this meeting. And why I am telling you this? Today is the National State Service and universities. Nobody contacts us even with letters, and our society, which is a professional society, we can do it And as we are the members of the European society, people will listen to us correctly, and I hope that we will wait until the fast decision will be taken about the internship for 3 years. It was very important at the conference. Mr. Strilka was present and director of main directorate of high technology and new technologies of rehabilitation. It would be very nice to bring back the 3 year internship for the doctors, not to torture them and to let them to take exams, to pass exams for European certification of physical and rehabilitation medicine. So, the general meetings of the society, you see our local offices, there will be changes in the statute, and please look at this with all your respect at this event. And finally, I would like to remind that on the 27th and 28th September in 2024, there will be a fourth national Congress of Rehabilitation Medicine, and all participants of today's forum are invited to this event. Thank you, colleagues, for your attention, and I wish you peaceful sky and um, clear future. So if you have any questions, please ask. I will be happy to answer. Thank you.
Dear colleagues, thank you. No questions from the audience. We are very happy to hear about the magazine, about international documents to document injuries. Thank you. I wish success to the conference, Dmitry. Goodbye. Okay, next I would like to introduce our next presenter, Rostislav Ivanovich Danelko, physical rehabilitation doctor, neurologist, doctor of a facility we work with many years. That was a model for many and will still be a model for many. This is our military clinical medical center of the Western region. Please, the floor is yours. Share experience, please. Thank you, Dmitrovich. I'm very happy being on this stage together with you, and this is really a historical moment. Because in extremely difficult area of spinal cord injuries, we have singled out area called neurogenous urinary bladder, and we heard very many positive and good things today already. I would like to share our experience of military medical clinical center Western region, the way we are doing that, what obstacles we had, how we are coping with them, and how we work now. This is our team. Within this team I prepared this presentation: Yulia Ivanovna, Doctor of Physical Rehabilitation Medicine, Colonel Viktor Romanovich Skoropat, is manager of our clinic and does everything possible for clinic to function very well. Importance of the topic. Well, injury of urinary bladder for patients after injuries of the spinal cord is called neurogenous urinary bladder. This is right terminology. If we may, let us call this pathology right. So neurogenous urinary bladder is one of the most difficult complications after damage to the spinal cord. Most important is right studies and management. The objective of management is not achieving the previous state, but safe loading and voiding urine that our urologist mentioned many times already today. Our rehabilitation department started working with spinal cord injury patients from 2014 in the first stage of war, and first spinal patient arrived right to our hospital, and we didn't have any idea how to work with them, and didn't have any idea what is constant Foley catheter, what is intermittent catheterization. Didn't hear at all. We are facing the issues and questions that we are asking ourselves. I think each one of you and those who hear us now online ask those questions to themselves, face this, and will try in the process of this presentation give bit by bit answers to those questions. So what Dr. Ruth was saying, do we need, one of the main issues, do we need to block the constant Foley catheter? This is very dangerous because we do not understand first the volume of urinary bladder, because there are damage by upper motor neuron, lower motor neuron. We don't know the stage this patient in. If the patient is placed in adjoining department, we don't understand the type of damage according to neurological classification. We don't understand 24 hours diuresis. So in the departments where they block the constant Foley catheter do it a bit wrong. These actions may cause hydronephrosis, infection to upper urinary tract, and further changes, and the consequences may be very negative, even lethal consequences. So please avoid this. We shouldn't block the constant Foley catheter, shouldn't be doing that. So the issue we're still facing difference between epicystemic catheter and irretrograde catheter. Do we need to train? I mentioned. Do we need to have electrostimulation of urinary bladder? Why? Young patients have possible arterial pressure going up to critical levels, not characteristic for young people, up to 200 to 300. Many people of reproductive age have intimate relations and give birth to children. And what Dr. Urologist mentioned today also, can patients who have removed constant catheter and mechanical squeezing out the urine. Remember this good Red Cross doctor, yeah? First elementary steps in managing neogenous urinary bladder that each department manages patients after spinal cord injuries is managing cart of liquid drunk and voided. Elementary things that will give you possibility to understand how much person drinks, how much a person voids urine. Usually in subacute, acute injury, in acute stages, we see the symptom called polyuria, and patients may give 3, 4, sometimes 5 liters of urea a day. You can imagine what happens to urinary bladder when it is strained, when urinary bladder is blocked for 2, 3, or even more time, when a nurse forgets to remove the blocker. So maintain this card, it will provide you very much information. I will speak more about this now. Also today my colleagues mentioned the condition called asymptomatic bacteriuria. Every patient that had constant Foley catheter installed has some bacteria that arrived from the healthcare facility he is stationed. It may be 2 bacteria, sometimes even 3 bacteria. We shouldn't treat them if there are no clinical symptoms. Our tactics in our facility is as follows. At the day of administration, next day we do the urea sample for the sterility and susceptibility to antibiotics. We know who lives there and what those organisms are susceptible for it. We do not treat this bacteria till the moment we have clinical symptoms. And clinical symptoms in high fever, change of urea color, change in lab tests, general blood test, general urea test, and so on. And when we see that the ailing patient has aggravation of chronic cystitis, we start administering those antibiotics that this bacteria are susceptible, that we inoculated for. This is our tactics that we developed based on our experience and based of familiarizing ourselves with different international protocols. However, In order to start treating neogenous urinary bladder, we need to understand very well what different types of spinal cord injuries may happen. This information is provided to us from international standards of neurological classification of spinal cord injuries, and those who visited trainings know what is ASIA. We call simply where you treat the patients after spinal cord injuries. Please do this test. You will understand more understanding where this is upper motor neuron, lower motor neuron, maybe this is a conus area damage, maybe combined damage, and based on that you will know how to manage neurogenous urinary bladder, because 1, 2nd and 3rd urinary bladder and lower urinary tract may behave absolutely differently. So if the damage level at the level of upper motor neuron, the most characteristic, so to say, hyperactivity of urinary bladder and sphincters, loss of coordination and dysynergia that our colleague urologist also mentioned. I'm thankful to them between sphincter and detrusa, called detrusa sphincter dysynergia, damage at the conus level, maybe combined acontractility and hyper irritation. If the urologist doctors here at the level of cauda-equina or cauda-equina syndrome, lower motor neuron as a rule lack late urinary bladder and late sphincters. We need to understand, of course, physical rehabilitation doctors to understand ASIA or international standards of neurological classification, where to perform this classification, to bring physical therapists, and together with the therapists have international standards performed, and understand as a team the level of injury, and after that to choose the tactics of managing neurogenous urinary bladder. Once again, levels of damage at the conus, epiconal level. I will not dwell upon that because a little time left. And I will repeat once again. One, damage to upper motor neuron. This is possible, called detrusa sphincter dysynergia. So different types of damage to detrusa and external sphincter that may manifest very differently. And urodynamic study gives us information what may be the real condition of detrusa or sphincters, and this classification is called by Madersbacher. And today I was pleasantly surprised because I heard from urologist doctor who just told what is autonomous dysreflexia. Only because of that it was worth starting this conference. If at this level our urologists are going to understand what level the injury may be to cause autonomous dysreflexia, I think that very soon we will have very good urodynamics, so to say, in different healthcare facilities of Ukraine. I will not dwell upon above T6 level, but I would like to underline that reason of autonomous dysreflexia. The main reason of autonomous dysreflexia is the problems with the urinary bladder. So managing neurogenous urinary bladder is very important in order not to provoke autonomous dysreflexia. We may talk the whole day about autonomous, but we'll stop at that. However, to start managing neurogenous urinary bladder, we need to single out between those two notions well. We need to understand what is neurogenous shock and what is spinal shock. Neurogenous shock is shock appearing right away after injury to spinal cord. The shock may last up to 5 weeks, characterized by acute vessel tonus drop. Patient requires the emergency care and vasocompression therapy. Spinal shock is a bit different shock or different shock at all, which is characterized by temporary loss of spinal motor and sensor reflector activity with gradual renewal of reflexes in case of spinal cord injury, caudal, aggravated or no causal may be maintained. Spinal cord injuries may be different, full or incomplete. If incomplete, different types of damage may last different periods of time, several days to several months. Everything is very individual. However, in order to start managing neurogenous urinary bladder or to remove constant Foley catheter, we need to understand when the spinal shock regressed and when we may allow ourselves to start removing catheter. There are two very good symptoms or reflexes that the doctor physical and rehabilitation medicine should do, and to determine the spinal shock stage regressed or not. First reflex is called bubble cavernous reflex. Raise your hand please, those who know how to perform it. Great. You need to have a finger into rectum and have irritation on the head of penis or clitoris. We will have anus contraction. S2, S3, S4 spinal cord happened, the loop is closed, it happened. Second reflex, we do the irritation near the anal sphincter, near anus, like blinking, something blinking to us. Second simple reflex that does not require so much intervention. We understand that spinal shock stage regressed. We may remove constant Foley catheter. We may switch to intermittent catheterization. So today, again, from the mouths of urologists, we heard intermittent catheterization. Hooray! We are very happy that we have urologists who know what is intermittent catheterization and recommend to our patients to have intermittent catheterization. Providing regular voiding, one of the safest program managing after spinal cord injuries. Beside that, advantage to the patients is less negative image on their appearance and genitals, because no drainage and no visible negative signs. People who have wheelchairs users, they understand very well when catheter is in you and what it means when you catheterize yourself 6 times a day. Advantages and disadvantages: imitating normal functions, avoiding urinary bladder, no side effects which are usual for the constant Foley catheter, gives freedom to express sexuality, prevents risk of complications. But as everything's got indications and counterindications, what are shortcomings or limitations? Person is to follow consumed liquid, so to say 24 hours consumption of liquid is to be dosage controlled, very reasonable, so person is to understand the way he or she consumes liquid. Some people may think that this process is uncomfortable and painful. When person catheterizes him or herself, a little blood comes out, start calling it night. What should I do? Should I go to hospital or not? You need to tell in detail patient and to speak of possibility of a little blood in urea or at the tip of catheter during catheterization. It's not so very frightening, and to give some adjustments. Women often think intermittent use difficult because difficult access to opening of urethra. Yes, but this is activity of our healthcare facilities, medical nurses and occupational therapists. Some catheters may cause too little damage to urethra, which may cause a little blood. I spoke about this already. However, in our department, I don't know how many years now, 7 or 8 years, maybe more, we use this little miracle device called the bladder scanner. This device is portable. You will tell now, ultrasound, everyone will think, oh, we are going to buy ultrasound. No, this portable device performing function like ultrasound, which by pushing one button measures the volume of urea in urinary bladder. It takes 30 seconds and our medical nurses apply this. We see how much urea in urinary bladder and see how much after refractory or voluntary voiding urea is left in urinary bladder. We use this device, but it is not certified in Ukraine. So I do not know, maybe someone does some conclusions and does it like because this device is to be in every neurological department, where the spinal patients, urological department, and department where people are on rehabilitation with damage to spinal cord. 3 seconds, 10, 20 times a day. A nurse is moving around all the patients. She may put it, measure it, especially to people who just removed catheter because person is in stress. Hormones are secreted during the 30 minutes. Half a liter urea may be accumulated, so dilemma to make it 6 or 7 times for a person. Philosophic question, but remember that they may be different sizes, but this device will simplify your life a lot and your patients a lot. What else may influence retention or incontinence of urea? Understanding medical history to understand drugs person who's administering, the sex, the age, previous pelvic injuries, possible medical conditions before spinal cord injuries, maybe previous surgeries, maybe some issues related to health before spinal cord injuries, and we may now relate everything to our injury. For instance, what constant Foley catheter may implicate? It means lengthy stay as inpatient, costs for treatment and treating complications, cystitis, urinitis, hydronephrosis, kidney deficiency, epididymitis. 2 times I had when a patient had the testicle amputation because of infection that was provoked by constant catheter stay. I know that those cases was pretty often, even in the countries I will not name those. The same problems exist, and they somehow do not make a right conclusion. When this problem is, we need to install epicystomic catheter. Indications, contraindications, urethral epicystomic catheters will not dwell upon. This is separate topic for discussion. But if a person lives outside the hospital and this influences the quality of life of the patient, I would like to dwell upon innovation of a lower urinary tract so that we understand better how and why some problem occurs. Colleagues mentioned innovation of lower urinary tract, innervated by somatic and vegetative nervous system. Vegetative is divided into sympathetic and parasympathetic. Parasympathetic pelvic nerve, the S2, S4 segments. Spinal cord contracts detrusor and relaxes the urinary bladder and function of voiding urea. Sympathetic nervous system at the level T10, L2 on the abdominal nerve, relaxing detrusor, accumulating urea and contracting cervical urea bladder, and our conscious control that we may carry our urea to the place that we may avoid when proper, near the shameful nerve. 3. Started managing urinary bladder. We need to understand the innervation areas and possible types of damage. General rules: volume of urinary bladder is different for different people, especially after spinal cord injuries. Especially today it may be 1, tomorrow a bit different. Person start administering some drugs, maybe it's because of stage of shock, maybe infection manifested that causes spastic, and lining up everyone saying that our urinary bladder is 500 milliliters volume. We shouldn't do that, especially after damage to the spinal cord. It may change after damage to spinal cord. Residual urea. I'm saying things that people very often ask questions about. Everyone says we know what residual urea means, but it's not the urea that we collect during periodic catheterization. This is urea that remains after voluntary or refractory urination. DRS is volume of urea. Now I'm speaking about spinal cord injury. DRS is the volume of urea going out during intermittent catheterization. And what is the most dangerous in all of that? that many people draw too little attention to is leakage. It is saying that bladder is overfilled and it is leaking outside. It's very dangerous because this slow pouring out or leakage may be very big risk of reflux of urea into kidneys. What will also be very interesting for you, possible signs of renewal of lower urinary tract, sensitization in perineal area, voluntary anal contraction, bubble cavernous reflex, feeling urinary bladder full, sensation of wishing to urinate, and ability to control urge to urinate. How to rectify problems of the correct management of urinary bladder? We are to understand the urinary classification, and to understand the upper urinary tract condition based on ultrasound, that we need to do x-ray test of urea and blood, and to inoculate urea, understand balance, sitting, other positions, functions of hand, physical occupational therapists help us understand the style of life. We shouldn't remove catheter for everyone. If people live with catheter, we need to understand where this person is going to go, who lives with this person, his mother, father, wife. Will this person be able to keep catheter himself or herself, or someone of his relative will have maybe some additional aids, custodian, safety, life devices, and so on. It all depends on many factors. I'm exceeding my time. I think that you are interested. Family doctors are to definitely understand at least elementary things, because patients with damage to spinal cord, saying that you go to a nephrologist say go to urologist, patient is running around between this triangle, does not know what to do after he showed some symptoms or signs. Physical rehabilitation doctors should understand the international standards of damage neurological classification as a result of spinal cord injuries. All the syndromes in case of spinal cord injuries, physical rehabilitation doctor is to understand who manages patient, possibilities and importance of result of your dynamic status. I do not understand all of them. Metro understands more. The healthcare personnel, medical nurse is to understand better rehabilitation, medical nurse. Hooray, rehabilitation nurses here, trainers, the medical schools, those are main hands, neurological a nurse who may measure right, who may provide right intermittent catheterization, sterile intermittent catheterization, nurse who's got a blood scanner. In Lviv, in college, after diploma education, they train rehabilitation nurses, and they started doing right steps in the right direction. Clear 24 hours monitoring of consumed and voided liquid availability. We should have at hand urologists like Lilia Yurivna or other who understands what autonomous reflexia is. I'm joking, but it should be urologist and neurologist who will sit together with you, think well, understand why you want to remove catheter. Okay, I will install episiotomic catheter, remove it, or I will think how to better manage this patient. This person is to be a member of your team, and you should know that you will call this person, and in any complications during macrohematuria, during other problems, during nurse unable to cave patient, trying to do it for more than an hour now, and this member of the team is to know also international protocols. Besides clinical evaluation, possibility of having the comprehensive urodynamic studies, I'll not dwell upon here. Having mentor trainers, we're not mentioning it today yet, but those are very important people that we need, that healthcare facilities need, like this center, facilities like military hospital, Lviv, facilities that manage patients. Those trainers help us understand a lot the internal world of the patients, and to help us adopt the right tactics for treatment. Yes, however, we have to understand that urinary bladder, in majority of cases, is in connection with neurogenic intestines. I need to set up, manage the program of intestines together with the neurogenic urinary bladder, and that all influences the patient's quality of life. Resources. Now I'd like to thank wonderful team Momentum who translated this clinical guideline, and I'm asking everyone to use this as a tool. It is already integrated to official website, and thanks to this guideline in Ukrainian, you may use it in your healthcare facilities. You may go to your colleagues and say, do not do this because clinical guideline is writing this, or approve it on your levels, the way the St. Petalemon Hospital did in Lviv, and use it. This is very good resource so that you may manage right. Many answers to all of the questions there. So please use the training courses called InStep, OSTEP, Eurostep. By this reference also, Momentum team is translating, integrates to official websites models of international community damage to the spinal cord based on this result bit by bit. They have models for all the members of the team, for the user, for the nurses, for doctors, for everyone, everything relating to damage to the spinal cord. Take it and use it. And I'm thankful everyone for attention. Sorry that I've exceeded my limit.
Дякую.
Thank you, and we felt once again your powerful experience and why people are looking for it again and again. There is a comment and a question. No microphone. Just a couple of remarks. So, if you saw blood with catheterization, that it was wrong. So, urologists recommend just lubricate and including catheterization. Please lubricate. And the basic of catheterization is good lubricant. Just don't spit and not saline solution, but this is the basic, and practically people do not understand, especially for men, long urethra and 26 centimeters plus external, just a lubricant, just a drop of lubricant. You think that it will go on? It will not. It will never go on. So retral, there is a solution. First of all, second, so leakage. It's not when only when the bladder is full. So there is a moment when urine can leak when there is no urine in the bladder. So what the volume of urine? It's the volume of the bladder, but a diarrhea is how much urine the person can make during the 24 hours of catheterization. And when we saw the curve of liquid drunk, and it's very good, the sensitivity and the volume of the bladder, and you will see whether this volume grew and reduced them. So thank you very much for this comment. I think that professor is right. And thanks for good lecture, and I'm both hands for the lubrication. And also I would like to ask you to just take a breathe out. So yesterday we provoked autonomous, and he's got a good contracture of the redra, and the more the more you put efforts, the more you have problems with urethra. So rehabilitologist yesterday tried to put the catheter after 500 milliliters. So please, otherwise you will go into cycle and circle. Have a breath, just make a injection, have a and then he will not urinate. He is cold. He is dreadful, and he will not do anything without taking the urine out. And you should take out the autonomous, otherwise you will not take the urinate. And you know you need the urologist in this way. But if you can do this function, don't be afraid to make a step back. Just recognize your error, and to make a step forward. So quiet down your patient, as you will never catheterize the sphincter, which is having spasms, and the patient will not be very thankful to you. We invite you to Lviv, and thanks again. Thank you, Dmitro, for this discussion. I think that everyone felt again how such meetings are so useful when rehabilitation doctors and urologists meet each other. Once again, I would like to invite Irina Kaspryshin, head of the Department of Physical Rehabilitation and Medicine, neurologist, PHM doctor who united us in this event, and you could see what was during the excursion. Thank you, Dmitro. This time you didn't miss my surname. Dear colleagues, now we will go to more general topics, and we will get a bit of more rest, and we will speak about the problems. I think that they are almost common for all the rehabilitation departments of Ukraine, and you will see your own problems as well. I will stop a bit on the basic points. We will discuss the well-known things for people who are here, and things not known so much to people who look at us online. And I will start that our hospital started a rehabilitation journey from the 1st of September 2017, when the Republican Center was created. It was headed by Ruslana Klimovich. And 1st September 2022, we opened department number 2 of the Republican Center of SCI treatments, because we needed the beds, because the 50 beds in the first department were not sufficient for the problem, and so the second department was opened, and on the 1st January 2024, two departments were unified and merged, and we created a new department in Ukraine. So this is the new name, physical and rehabilitation medicine for 100 beds, and we also added the workshop of wheelchairs and the rehabilitation room. So several photos of our general teams of two departments once, and I love when our patients in the center, they become our colleagues, and our interns becomes our doctors. It's very nice. So the team, during our work, we, from the multidisciplinary team, we went into interdisciplinary team. What's the difference? At the beginning of this, everyone in our staff, physical and or occupational, did its his or her own work, did did the work well, but it was not a general and or common. We even didn't know who does what and why. And during this, we entered into interdisciplinary approach when every member of our team knows perfectly what his or her colleague is doing. Occupational therapist knows what is physical and rehabilitation is doing. Psychologist does what the others are doing. Social worker knows what are the problems of the patient at home and tries to find the contact with social service in the region where the patient came here, and we gather every week and we discuss about the patient, who can do what, and we do it together, and we understand what the members of the team are doing. So not for nothing I took this slide, because we will speak what are the problems which we faced, and today Alexander said social work is very important, and we saw in our experience how social work is important in the team, and in this way our team is looking like, so we have the instructors of a first contact, and it reduces our need so much, because people in the wheelchairs, and they understand the problems of our patient like nobody, and it's much easier to find the common language with the patients, and including the members of the family, because there is no patient without family. And a couple of obstacles which we saw in the efficient work of the teams. So there were the interexchange of roles. Today you're working as a physical therapist, and tomorrow you can be occupational therapist, and sometimes you can be um, kind of medical assistant. You can be a nurse and something else, and even social worker. Sometimes we need to replace each other, so this prevents us from efficient work. So exchange of adjustments. What does it mean? Because during the work we can find a new diagnosis which prevents us from doing the rehabilitation process. When the reform changes our approaches and corrects the process, and so we needed to be adjusted to the needs of time and Ministry of Health. So that changes the speed of work. Medical hierarchies. So in Ukraine, this is mostly vertical, but rehabilitation is not the vertical. There is no one person who is on the top saying you do this, and you this. This is the team where everyone is responsible and equally responsible. Okay, case and social worker, you are the doctor, you are the occupational therapist, and everyone should know precisely where and why you are going, and nobody should have the right to tell you do this. Everyone does his own work as he knows better, and then individual character of the medicine, medical care, because when the team should understand the different phases and stages. So it could be aggravation in the vascular system, in the kidneys or nervous system. The team should understand, but sometimes the team does not know, and this is obstacle as well, and instability of teams as well, because of turnover of staff. Sometimes we need to say goodbye to some specialists, and this takes time to be um, ready for new work and for introduction of the person. It takes time as well. It's very good when everyone is at his or her place and knows what to do in the quality way. And next thing what I would like to mention, what we see with eyes and with our feel with our hearts, the root of the patient inside the facility. We know very well from the entrance department to the exit. We know what to do, but the root of the patient or just history of this patient before our institution creates problems for us when we take the patient. The majority of patients, they got the trauma because of military actions, or maybe some civilians, and they should get the quality rehabilitation at every phase. And I will remind you about the periods with which we, in the biggest way, we are working. In the acute period, the patient is sent to specialized clinics, for example, neurologic department. In the neurologic department, they get assistance, and the patient should get the rehabilitation in invasions, intrusions. So support of the muscles and joints and verticalization support, and at this phase up to 72 hours the patient should be evaluated. As you know, as Asia, for your knowledge of the primary perspective conclusion, to know what we will be working with and what we will create as a plan of rehabilitation after the acute period, when the person does not need 24 hours care of the specialist, when a neurosurgery assistant is not required. So these patients go to the fixed institutions, rehabilitation departments specialized in a certain way, types of trauma, as it is could be desirable. In these departments, the patient should get the full recommendations on additional supportive means of rehabilitation, and the consultation on the jobs, and a place of living could be provided there. At this phase, the patient could be trained how to use the additional tools for independent functioning, to know the skills for self-support, changing from bed to the wheelchair, personal hygiene, use of food, and so um, to use the principles of bladder and bowels and the respiratory system, take care about the skin, and foresee the complications on the skin, uh, the caregivers should be trained at this phase as well. Why should I tell you this now? Because very often we get patients without primary testing. Very often the patient are coming with void dreams which they got in the primary fixed hospital. So you can go to another hospital, you will get on your feet. And when to talk to such a patient, when the surgeon was telling him, the person who is very close to God, who told the patient this, it's very difficult to tell him something different. It's a bit too difficult. So we have to know how to tell the truth, but we can tell the truth when we have the primary testing, when we have the precise understanding what are the perspectives of this patient, and the patients with secondary complications, the patients um, with um, difficulties, the consequences of third or fourth stage, so which needed um, mm, the involvement of the specialist, or even plastics, which can postpone for indefinite time. So we lose the time, we lose the chance of the patient to be rehabilitated with his level of trauma. The patients who do not get or didn't get the services. Not all the fixed hospitals have the specialists, and not all the fixed hospitals understand what to do with the spinal trauma. That's why sometimes we have the patients who come without being trained at all. So at some sixth and seventh cycle of rehabilitation, you go to Klevan, they will help you there. But we are not magicians also. So hospitalization of the patients at the final phase into a specialized department. So this is a problem of loss of time for the patient. And a small slide now. That's what we faced in our institution, and a small slide which we did for comparison when patients came before 3 months and when the patients came after 3 months. What the soon as the patients are coming to the specialized department, the better chances these patients will have for the recovery. And so big request to the people who have the spinal cord patients, send them to the specialized departments. Don't wait that the miracle will happen. Send them to the people who know how to deal with this. And next is that is bothering us when we got the social worker and we understood how bad all is. This is a return of patient into the society. Why is this the problem? Because we have after acute patient, and when the patient goes home, people do not wait for him. No rehabilitation in the community, whole life medical assistance where the patient can call for the doctor for catheter if there is a sore ulcer. Um, these patients come back again to us in bad condition, and that is why it's very important to um, arrange the cooperation and um, contact with the social services who will control in which environment the patient will come back, that his place of living is equipped to be received. So the contact with job centers, because we need to train this patient to give him maybe a new profession, or to teach him to do something if he didn't get if he didn't have any profession, to make him feel important when he gets money. So it raises his dignity, and he understands that he needs somebody needs him, and first of all himself, he needs himself. And this is the first step of cooperation, and we try in this way to move on. Rehabilitation in the community, I already told you. So it should be a rehabilitation specialist who will come and will help him to live where he will live, and also lifelong medical assistance, and cooperation with hospitals, and what I mean, because some patients they don't have families, and they don't have where to live anymore, so they cannot serve themselves, and nobody needs them, and then they shift from one institution to another, and they wait for, they don't know what they are waiting for. But for sure, Ukraine should have such institutions, for sure. No barrier approach, and we talk about this always, and we go with patients into cities, and we talk to them on social things, and sometimes we cannot come up because we don't have elevator. We cannot overcome the obstacle, and we need the assistant of a physical therapist. The state of roads, the network is not adopted, adjusted, and these are the problems which we need to solve, and of course accessible public transportation, so to say. So this is the way I depicted some points, and we can speak about problems um, without end. It could be a conference what worries us, but just remember that barriers are only in our heads, because are always people who can help to overcome them. If it is only bad asphalt, it's nothing, because it can be only the problem inside ourselves. Thank you for your attention.
Я
I don't know what we are going to speak during the next presentation about. Thank you, Marina. Alexandra, as usual. Again, Dmitro Dmitrievich Raskevich works in the Regional Hospital for War Veterans. Our, I don't know, difficult to say, a dark horse who is taking on all the dirty, difficult work and has got wonderful results. But what I remember, Dmitry doesn't want to introduce himself. Praise God, he wrote on the slide, he is the manager of Rivne, a standalone unit of rehabilitation medicine. He is a big boss, at least at his office, though he does not position himself like that. He's an open person. And please addressed to him as a manager, friend. I don't know. I was twice introduced. I don't know why, but thank you very much. He understood already. My topic is providing rehabilitation assistance with the spinal cord injuries in the acute rehabilitation period. Yaroslav Ivanovich, Irina Alexandra spoke a lot about problems with skin, what we face at subacute stage. We understand that there are many problems, but we work in order to improve this somehow. I will suggest several slides for this topical area concisely, because there is time limit. We go to official documents that tell what is acute rehabilitation period, because when we, I will mention later, trainings for rehabilitation acute spinal cord injury period, maybe for other doctors, other specialist rehabilitation professionals, always question is asked, what is this acute period, when does it end, and so on. We shouldn't invent something. There are some clarifications that we may refer to, and you may read here. I will not repeat. And the rehabilitation assistance of low level should be provided so that all that huge armada of complications shows up, that in detail esteemed previous presenters spoke about also, so that they see that there is a route for the patient. So I understand there's a document, will not say to which extent it is a function in Ukraine, but it is being improved. There's a certain foundation, certain stage. However, we see that acute stage in our rehabilitation route in the spinal cord injuries and neurosurgical or other specialized healthcare facilities, where at this stage rehabilitation assistance may already be provided. Who may provide it? Not the neurosurgeons, but the invited neuro-rehabilitation specialists that they will take care of and will assist and will be very good colleagues to prevent all this massive number of complications that may take place during acute stage, especially bed sores, breathing problems, and so on. In terms of our rehabilitation route, what assistance provided in acute management of urinogenous urinary bladder, support, stabilize the neurosurgical injury or spinal cord injury. There were cases when guys were coming to us, preliminary request, okay, but they come again, we need to do once again test when stabilization of spinal cord necessary. We don't have it yet. This is what we think of, that what we fight with, not have similar things. Our rehabilitation route has detailed reasons of transfer in subacute period of time. What do we have here? Stabilization in order to possibly verticalize. No, the bed stores, stagnation pneumonias, and periodic clear self-catheterization is performed. Evaluation, rehabilitative, and the decision made by multidisciplinary rehabilitation team of facility about possibility to switch into subacute period. Often we note when we take epicursis, the conclusion of medical commission when the documents received. Sometimes we have this, but not very often. It was already mentioned. Insky very well, and esteemed Professor Alexander Arkadovich mentioned that we will soon have official Ukrainian language translation of international standards for evaluating spinal cord injury, classification of spinal cord injuries, and Savsky international standards of documenting infringements of autonomous function after spinal cord injuries. Those are two I will say sisters, they will add one to another, like medical classification of diseases and other medical classification. It should mandatory be performed. We're mentioning 72 hours. Definitely the condition consciousness state allows. If person is unconscious, it's impossible to perform. Why this slide? Segments of spinal cord, segments of vertebra, bone structure do not coincide between one another. Often when we come across description of the patient diagnosis, we see that a certain spinal part of um, um, indicated, but sometimes certain vertebra is indicated, and that's wrong, because that's why we insist on INSCI. It's not about vertebra, but based on INSCI, because position may be 3-4 vertebrae long. INSCI enables to say exactly which segment, why, so that patient knows, so that some forecasting may be done about forecasting. There are discussions, or people ask, can we do INSCI for patients with non-traumatic origin injuries of different other origin tumors and so on? Possible to determine neurological status, however not for forecasting. INSCI is created only for prognosis and for forecasting injury origin. When we are at acute stage, have INSCI. There are many studies that allow us to do some forecasting for restoration, functional or other. It does not mean to return to walking before injury. This is probability to return to autonomous walking. Maybe slow, but on their own. This is acute stage. When person arrives in subacute stage and so on, person does not have certain information. We should always provide this patient information about this prognosis. It is easy to do when we all have the initial evaluation when needed, because the majority of real and, so to say, substantiated forecasting may be referred to timely INSCI. Done several next slides to add to the previous presenters. How efficient, how more efficient rehabilitation is when patient arrives as soon as possible after injury takes place. I remember the previous year, East Coast International Conference on spinal cord injuries in Edinburgh, Glasgow. We went there later. National Rehabilitation Center of Rehabilitation after Spinal Cord Injury, wonderful center, so to say. But what am I leading to? What they told us, the average time period from injury to hospitalization as inpatient in their facility, 2 days. 2 days. It's just amazing. Maybe this is the highest indicator in Europe. If the hospitalization is delayed in specialized rehabilitation center, how much the probability higher of complications from skin to respiration and so on. We know problems, we know difficulties, but we are looking for the way to resolve those, and one of the solutions within WHO, support from WHO for certain time, we were traveling with the national team to healthcare facilities, and we're visiting with another, learning, showing how to work, what to do with the acute stage of injuries in spinal cord. Another stage ended. They went from us. They continue work in other places with other rehabilitation teams. Why? So that problems that we discussed all, try to decrease them. If you make them less in acute stage, will lead to good work in subacute stage. Patient will improve the probability to return to work, as it was mentioned at the beginning, if accessible. Thank you for your attention. I will not keep and next I would like to invite
Honorable Lilia. Maybe it will be very interesting to hear this topic, because we built it in the way that it would be different a bit between each other. Thank you. Maybe interesting, but it is not your topic, dear rehabilitologist. But a small remark to Dmitro. He wrote Dmitro Raskevich. If it would be Dmitro Dmitrovich, he would had some observations. So he showed the scale which we as rehabilitologists would need to understand, and a small remark to Dmitrovich. He should translate it into Ukrainian, and it was so difficult to translate it with a small digit and letters. ASIA is translated into Ukrainian. It will be at the website of the hospital recently, but other things about sexual life, also urination, they will be available at the website, and I hope that this topic will not coincide, overlap the previous speakers. It's very important because the dear rehabilitologists, urologists, neuropathologists, you categorize the patients who come from abroad. Please ask them if they have artificial implants, because just a small movement or just a forced movement can destroy a whole work of plastic surgeons and reconstructive urologists, and it brings the losses of dozens of thousands of dollars. So you see how these elements are looking like in the body. So life should be satisfactory. We know it not only from our own ideas, but WHO also would like us to have life as something interesting, depending on the lives, on the targets and the aims. When efficiency is appropriate, so we needed to use the artificial sphincter. So when erection is lost, we can use the processes of a penis, and if a testicle is absent, the processes of a testicle can be installed, and all problems can be also done with artificial sphincters, which is a normal practice in the world. So this story was changed during the dozens of years, and tools were changed, but today three component elements, they are composed of three parts. Why did I show you this slide? It's not a story that somewhere in a very big developed country it exists. It's just a banal story, but US pay for research $490 million per year to install the artificial sphincters. So it is recommended to acute patients who have incontinence after the operations, and all the patients who have incontinence neurogenically. So these are who have dysfunctional sphincter, not only because of CI, but other neurological dysfunctions like sclerosis or Parkinson's disease. And artificial sphincter has its own characteristics. So, first of all, bladder of high pressure. Never do it for the patient with such analysis. You will just kill him, and we need to check if the patient does not have compliance, and he should have um, tissues, intact tissues. Also, no obstacles if even the cancer is possible. So we have some leaflets for the patients to improve his life without explanations of all details. So the patient will understand what will be going on. On the other side, he will know what to do after the operation and what to expect for. So the video is taken from the internet, um, from open access, but it explains to to for you to understand. So this is the pump. The pump is inside the tissue. The patient presses the pump, and in several seconds, so he presses the pump in several seconds. So the reservoirs in this portion goes from this collar to this place, and the liquid goes out. So the sphincters they have the time as to reduce the number of pressures. So in 45 seconds or 1 minute, the collar is filled with water, and it closes the urethra. So artificial things, what the figures are shown, full stoppage of symptoms in 70% of patients, and only 3% of complications. The worst complication is the infection of urinal tract. In spinal patients it will be higher, so the majority of these complications are coming from SCI patients because they are ejected, they are destroyed by mechanical, some untrained movements and services. So we tried to connect to these statistics and to put our own influence in this, and we did two international researches from different centers, and the results were different from the and far away from themselves, and they were present at the international congress. And we showed the factors, what influences, and it was presented by Ukraine at the World Congress of Urologists. And in other contexts, we compared how this influences, what are the complications in practical, what is the erosion, what are the collars torn in European Congress, which was in Baltic states. And if we speak about the device which you can see in everyday practice, these are the processes of a penis. They don't save the life or improve the length of life, but they give the hope to spinal patients, and any urologist would like to have a spinal patient, especially for prosthesis. But more and more spinal patients, they reclaim this because they come back to normal life. So this erection appears when in this cavity cells the blood is collected, and so there is a tension. Tension is mm, fixed, and this state is called erection. So the processes in the penis should need the reconstructive urologist. It cannot be done every day. You will not see the patients who would do it in the regional center, because especially the spinal patients with filoprothesis did come from the big center, and ask him if he had some operations, because this operation, I will show you with slide, it is so natural that you, as if you never saw some other patient, and you will know, you will never know it is an implant. So the story is quite difficult, but last year, as a reconstructive urologist, we celebrated 50 years of appearance of prosthesis through components inflatable, which we use today now. So today we have one common component plastic on the top, flexible implants, two component. These are here. They are both of things which are introduced into cavernous things and bodies and pump that pumps and the three components. They are the most anatomic. So if you push this pump, so the liquid from this part goes into another part. It's almost as a direction imitated in the natural way. So the only argument for the two component processes, it's the price. It costs much more less than three components. But one component is a system of batons or sticks which are bent in an appropriate way. You can do it yourself with a hand, and direction is gone. But with three components, the problems are much more numerous, because in the inflatable processes, besides the erection, which is very natural, there are more elements that can be broken. So the erosion of the intrusion or installation, and the pump which is inside as well. The video is also from internet, because one of the most famous companies who produces these implants, they do it to let the patients to select, to learn about the tools, and to come to the doctor without any additional questions. This animation from Boston Science. So the patient presses the pump, and the liquid goes from here. It fills the penis in some seconds, and the erection is going as long as necessary. When he presses here, the pump takes the liquid back. So it looks like anatomically very natural, and as we see on the bottom slide, and these works are done in the best way by Dr. Tobias Kollner, who travels in the world with lectures. He is the guru in the US. He works in Mayo clinics, and last year he published a wonderful article with 53 analysis of penises, but he didn't split with the spinal patients. The results were perfect. On this slide, it was done last year, and anatomically, these processes, it's difficult to differentiate. And the processes of the penis, it not can be done because of the trauma of the penis and the mechanic war injuries, but these were the normal clinical scenes. It could be Peyronie disease, so there is a plate that does not allow to have erection, and the patient decides to put the processes and without treatment. So the patients with sugar diabetes, almost all of them, they have problems with erection, and they cannot be treated with drugs. And then there are patients with psychogenic impotence, which cannot be treated by drugs, and they want to have this intrusion with processes. So in the section can be about the lumbar and there is no need to show the genitalia if the patient doesn't want. So there is the implant. And in 2-3 days, and the patients come back home with full functions. So there are no scars, and it can it make a confusion for you that there is no implants inside. So again, 50% for the processes, it's quite a lot, and for an artificial object, it's quite a lot. And as researchers in 50 years showed us that in this time the processes is a very reliable thing with satisfactory of 90% of the patients with low level of infection. So the processes of testicles, they do not influence the length of life, but for some patients they are very, very important. And normally we need to write the diagnosis, kind of anarchism, why this anarchism appeared. So then we explain on the paper, but it is not only because there is no testicle, but it could be the amputation of testicles because of trauma, and it can be a treatment. For example, during the oncology, there is no resection, and testicle is amputated. So on this slide, we see the both testicle processes. This is the transgender patient who changed the sex, and it was a transfer from a woman to the man, but the photo were very good done in Belgrade. There is a clinic specialized in gender transfer. They do it 2-3 per day, and the results impressive for me as a neurologist. It's difficult even sometimes to make the difference, but the majority of clinics they use the implants of very high quality. Previously we had such implants from Germany. They were of good quality, but the price was quite bigger than the patients expected if they have especially several operations. So our dreams about Coloplast or Boston Science or Swiss products can be different a bit, but last year, if you remember, we have a Rigicom company. I don't have any conflict of interest, but somebody in the urological chats, they ask where such implants can be found, where can we order them, and today this is the point which is not a problem anymore. We have Regicom registered in Ukraine and approachable by price, and testicle for processes has all components for fixation. They're approachable and they don't need to be ordered from outside, and the penis processes as well. So um, mm, the Dr. Krasikova, the head of a laboratory in Canada, dealing with SCI patients. He's a guru of spinal patients. He will tell you in detail more. Maybe he does not want to speak to this in this slide. So we expect that the length of life, it's not all we want from life, but we need the quality of life. But one more remark. If you don't know what is implanted, why it is implanted, with what it is implanted, don't touch it, don't put cassettes, don't destroy. In Ukraine, maybe it's not so often, but it is if it is mechanical damage and all the implants they have lifelong guarantee, the guarantee will not be avoidable. So if it is the plan is the pump, the warranty will be for life, and if there is the destruction by medical professional mechanically, so the warranty is not covered covering this. And the implants of artificial sphincter cost between $5,000 and $10,000, and plus operation where it can be done. And in majority cases, if it is done by negligence by medical professionals, the insurance companies, they know very well how to do it, and they do it in the whole world. And there are articles praising article how much the company paid the premium because it was done mechanically, and how they took for themselves. So the insurance company would not like to do it twice, and be careful two times. Thank you. So as it was expected, it was very interesting. So we have coffee break now. Don't go far away. Stay close, and there will be very interesting session after this. Thank you.